Next, we'll be looking at a general observation and inspection of the patient. Starting out with the anterior view, we're going to landmark the ASIS, the anterior superior iliac spines on either side. So it'd be here and here. And then we're going to observe, looking downwards at the general stance. We're looking at the knees to see if there's a genu valgus perhaps, a knock-kneed position, which would also probably go along with pronated feet. That could be an indication that there may be weak or inhibited gluteal muscles. The opposite, as we look down, if this was more of a bowing out, a genu varus, feet would probably be supinated and higher arches here, pes cavus perhaps, where you'd have a raised longitudinal arch. In that case, we actually may have shortened and contracted gluteal muscles. So looking at the front, we're taking all those things into consideration. Next, we'll observe the posterior view. Here we're using the PSISs as landmarks, so the posterior superior iliac spines. We're looking for the gluteal folds to make sure there's symmetry, the folds at the back of the knees as well. We're also looking to see if there's a hike in the pelvis, if one side's higher and another side lower, which would be indicative of potentially tighter, shorter muscles on one side, weak, inhibited on the opposite side. Any indication of that could lead into any type of imbalance or asymmetries in movement and in function. Lastly, we'll look at a lateral view. And what we're observing here is whether there's an anterior or posterior pelvic tilt. I'm going to use my hand to demonstrate. So an anterior tilt would be the top of the pelvis forward. This would indicate potentially shortened QL or hip flexor muscles. It will increase lumbar lordosis, creating more pressure and compression in the low back. It will also inhibit the gluteal muscles or is indicative of potentially weakened gluteal muscles that are not countering the hip flexor on the opposite side. Now, if we go the opposite way, this would be a posterior tilt. And as you can see, it flattens out the lumbar spine and the gluteal muscles shorten and contract. Either of these positions can lead to abnormal hip motion and potentially dysfunction. Next would be palpation. From the anterior aspect, we're going to palpate the ASIS on either side. We're always comparing left and right when doing this. Then coming downwards, we're going to find the greater trochanter on either side. And then visually, we're inspecting and palpating as we're going down to the lateral malleoli. If we were to measure, we draw a line from the ASIS all the way down to the lateral malleolus, and we would compare left and right. Next, we'll be palpating from the posterior aspect. First off, we're finding the posterior superior iliac spines on either side, once again comparing left and right, the PSISs. Next, we're moving to the greater trochanters on either side. In the midline here, we'd have the sacrum. Follow that down. And from here, we're going to go to the ischial tuberosities. Lindsay, is it okay if we palpate ischial tubes?
Yeah.
Okay, so we're going to go right side, left side. There are the ischial tuberosities. If we use the ischial tuberosity as a landmark and then the sacrum as a landmark, running from the ischial tuberosity to the sacrum would be the sacrotuberous ligament. So we're going to palpate that. Once again, we're checking both sides. So we're palpating here again. And then lastly, if we use the ischial tuberosities as landmarks and the greater trochanters on the external aspect here, midpoint between the two would be the sciatic nerve. So here's the ischial tuberosity, trochanter, midpoint. If we follow it down into the biceps, we could pass, biceps femoris is what I'm trying to say. We'd palpate sciatic nerve, or we could follow it up into the deep gluteal musculature as well.